Yes, sir.
Yeah. I thank Dr. Abhay Jain who has given this opportunity. I again thank one and all. And the next 30 minutes, I am going to talk about the what are the causes of breathlessness and approach to respiratory cause of breathlessness. And if you're taking causes of breathlessness, it's a important thing is a dysfunction of lungs and airways. It's an important gas exchange, important thing. It's the foremost and important cause of the breathlessness. Next one is coming to the cardiac cause. So this is again the second most common cause. And third one is you can see that CNS neuromuscular dysfunction and breath control centers, that respiratory center in brainstem, that's medulla and pons, any feedback mechanism affected, I think love going for breathlessness, central cause of breathlessness. And if you're coming to a fourth cause, increased metabolic demand, so not matching capacity, that means O2, CO2 exchange, it's not occurring. And a lot of metabolic causes also going to cause. I think we will discuss this later. And I think another one is fifth one is GI cause. This is very important. Any trauma and peritonitis also may produce breathlessness. And and sixth one is it's allergic cause. Sometimes urticaria also may produce breathlessness. May produce urticaria, angioneuritic edema. And important as a birth, you can see always everybody know that's hyaline membrane disease, newborn, and TTN and PPHN. These are the important causes of breathlessness. And anyway, I'm going to discuss mainly about that respiratory cause of breathlessness today. And as Dr. Abhay already elaborately discussed how the quick assessment of respiratory distress, we can use the pediatric assessment triangle. In case of respiratory distress, that pediatric assessment triangle and appearance circulation almost normal. The main problem is in work of breathing. So you can take it stridor and wheezing, retraction, rails will be there. So based upon that, we can conclude that the child is having respiratory distress. And another one is a quick assessment of respiratory failure. That's the important thing is failure. And in failure, the paired triangle, the three are affected. Appearance affected, work of breathing also affected, and circulation. And if you're taking appearance altered and consciousness, and will be there, and either increase work of breathing or decrease work of breathing. An important thing is the decreased tidal volume will be there. And in circulatory part, if you are taking, you can see that tachycardia and bradycardia. So based upon that, we can conclude that baby is having respiratory distress or going for a respiratory failure, impending failure. And what are the clues to respiratory causes? So the important thing is usually it will be a short duration and episodic in nature will be there, and seasonal also. Sometimes even most of the viral also may produce a seasonal thing. And in case of upper airway, you can think of noisy breathing, child will have stridor also. In case of lower airway, child will have cough, breathlessness, wheeze and grunt, and adventitious sounds, and distress with chest signs will be there. So important negative history. What are the important negative history you have to think of? One is no tender hepatomegaly, the edema. These are important things we can rule out from the respiratory causes. Usually, by and large, growth normal, unless in case of some chronic lung disease and chronic any immunocompromised child, that's a growth. Otherwise, it's a normal only. And come to cardiac causes, history is very vital because if you are taking the cyanotic, acyanotic congenital heart disease, you love child love signs and symptoms of that concerned cyanotic or acyanotic. And more than that, child love from birth onwards, feeding difficulty will be there. Definitely, child love, forehead sweating, and recurrent respiratory infections. These are all the clues to you can have history wise. And usually, as I said, no, it's a chronic in nature, and usually that's chest signs start in late aspect of disease only. And you can see that any myocarditis signs like tachycardia, gallop will be there, and signs of shock may be a present, and any that heart failure signs like edema, puffiness, and tender hepatomegaly will be there. And mostly that growth may be altered if you are using that IAP growth chart. You have to constantly monitor that growth chart is very important. Coming to metabolic causes, it's important thing is tachypnea. Child have deep sighing respiration. These are the two important things. And usually the sounds, no added sounds. Only that if at all it should be maybe pulmonary edema like that, late only we'll get the sounds. And next one is neurogenic. So neurogenic, if you are taking hypoventilation and hyperventilation. Hypoventilation because of involvement of brainstem and babies having coma and seizure and spinal cord involvement and nerve pathology. These all the conditions may produce hyperventilation. In case of hyperventilation, child have erratic deep pattern and you have to look for the CNS abnormalities and deeply child have comatose and because of hyperventilation, baby may go for CO2 washout and hypocarbia will be there. And coming to management, I am going to focus only the respiratory causes. In case of respiratory distress, so child is coming to ER with a respiratory distress. Main important thing is avoid separating the child from the mother. So babies happy with the mother or father or caregiver, allow the baby to sit on lap. So you have to allow the baby to be comfortable position. And more than that, the child maintain position of the comfort. Sometimes if you're coming taking that's a lot of many conditions like a tripod position, maybe will be there, and epiglottitis and retropharyngeal abscess. These are child, no, that may child lean forward, and you can go for a tripod position or bending forward. These are the positions will be there. So make the child to allow to whatever the position baby likes. That's a very important thing. And third one is provide oxygen in a non-threatening manner. So don't push. Sometimes baby may that's cry with whenever using that oxygen mask. So you can keep off inch away from that also. And HFNO. These are things you have to look for and avoid non-threatening manner. And next one is treating the specific cause. I am going to discuss it later. And monitoring the vitals. So monitoring the vital is a very important thing. It needs serial monitoring is very important. So you, based upon that serial monitoring, child is going for improving or not or deteriorating. These are things you have to assess. We can use a specific charts to monitoring the vitals. And in respiratory failure, the core important component of management is control of airway and oxygenation. So babies have to see that adequate oxygen or not. And the child is either in need intubation or going need a NIV like support or assisted ventilation. And serial monitoring of vitals is very, very important. And stridor, what you have to more important thing is acute or chronic. If a child is coming to ER, child is having acute means we have to think of epiglottitis or immediate means child was playing. Suddenly child is having stridor means you have to think of always foreign body. In case of chronic nature, we can see retropharyngeal abscess. So other causes also may produce chronic. So you have to think that the presentation is acute or chronic and able to maintain airway or not. So child is have a complete or subacute and incomplete obstruction. You have to always you have to evaluate oxygenation maintained or not. You have to always like Dr. Abhay said that you have to look for the oxygen saturation. If 94 less than 94 means you have to learning, you have to go auto, and you have to see the work of breathing also. And as like told that assess in position of maximum comfort. That child is allow the baby to comfortable position. And what are the differential diagnosis of acute stridor? And if you're taking retropharyngeal abscess, child love that's or some subacute onset, and baby love 2 or 3 days of fever and unable to swallow the feed also, drooling of saliva will be there. These are the causes we have to suspect, and child will be toxic also. So you can suspect retropharyngeal abscess. Sometimes neck stiffness also will be there. And in peritonsillar abscess, child have unilateral swelling and tonsillar enlargement also will be there. And the most important thing is epiglottitis, child have toxic and drooling saliva will be there, and child will be tripod position will be there. So these are the conditions you can think of this upper glottic, that means supraglottic involvement. Coming to group that laryngotracheobronchitis, will have brassica And other conditions like bacterial tracheitis and foreign body obstruction also you have to think of. This foreign body obstruction is one of the emergency. All of a sudden, cell presentation will be there. And in case of supraclatic, what are things you have to suspect? Peritonsillar abscess, and you have to think of retropharyngeal abscess, as already discussed, and acute presentation like epiglottitis. So important thing is drooling of saliva or dysphagia. This is important clue you have to always suspect. Any child with coming with a drooling of saliva, dysphagia, you have to think of that's supraclatic involvement. And if you are coming to infraclatic or clatic area, so child have laryngotracheal bronchitis, typically presentation early morning, and bacterial tracheitis also may presentation be there. So important thing is no drooling of saliva, presence of barking cough. That's a barking cough is one of the important thing. A metallic sound will be there, and no drooling of saliva. If it is there, you have to think of infraclatic and clatic involvement. So assessment of severity of group. So based upon their presentation, child we can categorize mild, moderate, and severe. In mild category, child of barking cough, stridor, usually fever will be a low grade only, and suprasternal retraction will be there. Usually, typically absent when child is sleeping or child is calm situation, and it's aggravated when child get agitated. In case of moderate or severe, child will have agitation, lethargy, progressive tachycardia and tachypnea, and saturation-wise hypoxia will be there. All acute stridors should be advised admission until you are arriving at diagnosis, and the child may go for any time, may go for a respiratory arrest. So all acute stridors need observation. You have to admit and observe. That's a very important thing. And coming to group management, so mainstay of management and additional treatment. If your main is child, you have to make the child in keep the child with parents and make the child be a position of comfort. That's a very important 2 points you have to always take. Don't meddle the child, don't prick the child, and don't make the child to go for a investigations, all those things. So may putting injection also may child get a cry and may aggravate. So next important thing is we can go for nebulized epinephrine. The dose of 0.5 ml per kg we can use. We can maximum we can go for 5 ml of the 1 in 1000 solution. You can use it. If the volume is less than 2 ml, you can dilute with the NS. This is important things. I think we can keep 10 or 15 minutes. You can go on dose. It definitely will reduce the edema of the clottis, and the child definitely will improvement will be there. Frequency, how frequently you can give means based upon the response and the side effects. You have to watch for the tachycardia, other side effects also. Additional treatment is corticosteroids. And corticosteroids, clinical efforts within 3 to 4 hours, you can get it. Important drug is dexamethasone. In case of mild to moderate cases, we can use single dose of 0.15 to 0.2 milligram per kg. We can use 8 hourly. That's usually 2 or 3 doses will improve. In case of severe case, we can go for 0.6 milligram per kg, and maximum we can go for 16 milligram we can use. A lot of studies shows IV and IM and oral are both drugs are both ways equally effective. And from some recent trials, they are telling nebulized budesonide. If unable to go IV or IM, so we can go for nebulized budesonide, and it will have, so definitely will affect, but need a lot of studies also. And third one is we can go for airway management. Based upon that, either it's acute distress and failure, we can go for airways, we can switch out to airway management ABC. And coming to child case scenario 1, 2-year boy with high grade fever, progressively increasing stridor with distress, and drooling is there, and the baby is toxic looking, no barking cough. As already discussed, the child is not having barking cough. That means it's a lesion is in the supraclatic area, and that means we can rule out bacterial tracheitis and ALTP also. And if you're coming to, it's a progressively increasing stridor, not a acute onset. So that means you have to think of retropharyngeal abscess, one thing you can think, and drooling also there. So basically you can conclude the diagnosis of retropharyngeal abscess. And how will you manage? So cause at any time of year in any age group will be there, retropharyngeal abscess, and much more common than epiglottitis in India. That's a retropharyngeal abscess. Always you have to suspect. And how will you manage? Priority attention to airway and oxygenation. You have to look for the airway, you have to look for oxygen saturation. So you have to give airway, and saturation is important things you have to monitor. If unable to intubate, so what you have to do, you can go for emergency tracheostomy at the emergency itself. And antibiotic, we have to suspect a gram positive as well as anaerobic infection also. So accordingly, you have to cover with antibiotic. And you can make the child to secure the airway, or if a baby is okay, you can take to operation theater, you can do incision and drainage if there is airway compromise. Before that, you can have any diagnosed problem, you can go for CT. That's also will give a clue where is the exact position of the lesion. Next scenario is 3-year boy with history of sudden onset, stridor, cough, and choking. This is obvious. I think it is a stridor, acute onset, stridor, cough, and choking. Love that foreign body. If we are coming to that PAT triangle assessment, appearance and circulation is normal. So only work of breathing is increased. It's the word suspect. This is a respiratory distress only, and it is an incomplete obstruction. And another scenario is same boy with a sudden onset coming with stridor, cough, choking, but assessment triangle shows altered consciousness and anxious and increase or decrease work of breathing, decrease tidal volume, and circulation affected. You have to think of it is a respiratory failure or it's going for complete arrest. So what is the difference between two? As already said, this is a complete or incomplete. First one is it's a incomplete. Second one is complete obstruction. And what will you do the first? What will you do for the second? We will discuss it later. And before going to the discussion, I want to tell about the foreign body aspirations. And symptoms of foreign body aspiration into the tracheobronchial tree, and maybe it's a complete obstruction means going for respiratory arrest. And in case of foreign body aspiration, there is a 3 way of presentation, 3 stages. One is first stage is child love, agitated and wheezing, cough and dyspnea. And mostly that 40% may have that asymptomatic thing. And if you're coming to second stage, may last 7 to 10 days. That is a asymptomatic time. So that's the time we will miss it. So if you're coming to the first stage, sometimes may child is having wheezing and coughing. We think of wheeze and we can give nebulizer or give us some medications. Baby will go. So after that third stage means again symptomatic. The symptomatic is due to the secondary infections or foreign body erosion. The bronchus may produce bronchiectasis and fever, may presentation like pneumonia. Any child presentation to the OPD with recurrent pneumonia, that is the same lobe involved second time or third time. Suppose right lobe involvement is 2 times, 3 times. Always suspect the foreign body. So about that, it's less than 5 years that foreign body is common. Any child comes to the recurrent respiratory infection confined to the same lobe, you have to suspect foreign body. So primarily we'll have diagnosed as LRI and we'll treat LRI, and subsequent CT evaluation, we can go for virtual bronchoscope image of CT. We can look for the tube obstructions. It's will be a foreign body will be there. So always we have to suspect in the case of foreign body in recurrent infection. Coming to that first the case scenario, and as already said, that's a incomplete obstruction. And in case of incomplete obstruction, patient will be alert and breathing, coughing, and producing sound, and allow position of comfort, allow to continue cough. Don't use the cough suppressant. Provide supplemental oxygen, and immediate consultation with surgical specialists, like many area that ENT surgeon may go for foreign body removal, or cardiothoracic surgeon or pulmonologist. Whoever these specialists, they are well trained in the removal of foreign body, you have to send them. And always evaluate the airway evaluation and removal of foreign body in the operating room. And coming to the complete obstruction, you can see that not moving air, no sound of cough, and progressive cyanosis. It's a source complete obstruction. And in this situation, you have to attempt ventilation. And if baby is no chest rise, so if baby is less than 1 year, give 5 back blows, then 5 chest thrust. This is a very important thing you have to teach them. And if baby is more than 1 year, you can give 5 abdominal thrust. So it give some life-saving thing. And if this is unsuccessful, what will you do next? We can go for perform direct laryngoscope. You can visualize if any foreign body is in positions in, we can try to remove with adequate precaution. And you can send for that surgical consultation for removal, and attempt vigorous bag and wall mask ventilation. And if necessary, you have to intubate. And in emergency, we can go for cricothyroidectomy. Coming to case scenario 3, 6-year girl, history of recurrent episode of cough, occasional breathlessness, typically no history of fever. And presently, child is having only breathlessness 8 hours without fever. On examination, child is anxious, speaks monosyllables, the increased work of breathing with marked tachypnea and retraction, and subcostal and then suprasternal and then intercostal recession is there. So I think it's a diagnosis obvious. It's we are dealing a case of asthma. So what are red flag signs for the asthma? Unable to talk or cry, cyanosis, feeble chest movement, absent breath sound, and fatigue or exhaustion, agitated, altered sensorium, saturation anything less than 94%. You are thinking these are the red flag signs, need observation or admission or ER management. So coming to asthma initial management, we have to supplement with oxygen if less than 94%. Next, this is the first drug, and next drug is we can use for nebulized salbutamol. So minimum dose is 1.25 milligram if baby is less than 6 months, and 2.5 milligram baby is more than 6 months, and you can go for 2.5 milligram to 5 milligram for the older children. Usually 1 ml contains 5 milligram composition, and dilute in NS only, because never dilute with the distilled water, because distilled water may produce the respiratory irritant and may produce this immobility of that mucus, and immotility of the cilia will be there. So always mix with the NS only. May aggravate hypoxemia initially, because we are giving a beta-2 agonist, it may produce bronchovascular dilatation. So because of the bronchovascular dilatation, may go for ventilation perfusion mismatch. So in this situation, may go for hypoxia. So always, if you are using clinic or if you are going for hospital, always mix with the O2 and given with the O2. That's very important. If you are giving, in case, so now that we are getting that COVID time, and sometimes it's a risk of giving nebulizer also, we can use meter dose inhaler. So 1 meter dose inhaler is equal to 90 microgram. That means, so you can use a 2 to 8 meter dose inhaler. We can use emergency purpose also. Same duration like nebulizer. And we can easy for them that also they can get meter dose inhaler, and we can manage accordingly. And you can see that beta-2 agonist complications like tremors, tachycardia, irritability, hypokalemia, these are things you have to look for. If that in spite of this management, child is still have poor response, so you have to go for repeat salbutamol nebulizer. You can give 3 doses every 20 minutes interval. And next we have to go for steroid. So steroid is we can give either oral or parenteral. We can all equally efficacious. prednisolone and hydrocortisone, we can give it 1 to 2 milligram of prednisolone. So in case of admission, we can go for methylprednisolone 1 to 2 milligram per kg. We can give it, and you can repeat methylprednisolone 0.5 to 1 milligram 6 hourly. You can repeat. And add nebulizer with ipratropium bromide 6 to 8 hourly if necessary. So you can now, we are already given oxygen, steroid, and nebulized salbutamol. We are giving hourly or second hourly, and we can sometimes we can do continuous nebulizer also. We can give it. And this scenario, we can go for magnesium sulfate. Consider magnesium sulfate. We can go for 25 to 75 milligram per kg. We can give it. In case of the child is having very severe asthma, we can go for up to 100 milligram loading dose, followed by 25 to 50 milligram 6 hourly you can give. And some studies also says that magnesium sulfate nebulization also we can give it. In resource limited setting, consider aminophylline infusion. So many centers we are not using aminophylline, but you can use a resource limited setting. We can go for aminophylline because it's a narrow therapeutic range. We have to at least once a day we have to monitor the aminophylline toxicity. We have to monitor, and so oxygenation, steroids, maximal inhaled dose of salbutamol are the mainstay of treatment. Other options may offer only small additional benefit. So, what are the indications to escalate to assisted ventilation? Child is having fatigue, lactic acidosis. If you are going for ABG, child is having lactic acidosis, and pulses paradoxus, hypoxemia, refractory hypercarpia, altered sensorium. Child is having severe nausea and vomiting. So these are the situation we can go for either based upon the presentation, we can go for a non-invasive ventilation or invasive ventilation. So important question is, why hesitate to intubate and ventilate? So two important thing is, if you are putting in ET tube, it may aggravate bronchospasm. And the second one is increase the risk of paratrauma. So that means you have to very careful to before intubate, you have to refer to the particular center or experienced person only. They have to try to intubate. So unnecessarily we should not make the child to get worsened. So progression to respiratory failure. So you have to what are the important things we have to manage, what are the supportive care, and rapid sequence intubation and mechanical ventilation for respiratory failure. Yes, already said, avoid as far as possible. And if a child is okay, you can go for non-invasive method of ventilations like high flow nasal cannulation and BiPAP also you can see. And ketamine infusion pre-intubation is very important because ketamine itself may produce bronchial dilatation, bronchial muscle dilatation, and ketamine also we can use. And the supportive care, so fluid resuscitation. That's a child is already dehydrated. You can go for fluid resuscitation. You can, as much as possible, if child is okay, tolerating, you can give oral. Otherwise, you can go for parenteral IV fluids. We can give. Avoid overhydration. Why you have to avoid overhydration? There is a risk of SADH in ventilated asthmatics. So you have to give an adequate maintenance dose and monitor the urine output and pulse volume. Accordingly, we can increase or decrease the IV fluids. And if a child is having come with signs of any secondary infections, consider antibiotic if documented only. Coming to the case scenario 4, 2-year girl comes with the complaints of high fever 2 days and child is having breathlessness 6 hours. On examination, child is drowsy, tachypneic, increased work of breathing, and flaring of LR-nasi, intercostal retractions. So obviously, it's a suggestion of lung disease like pneumonia. And child is pale and heart rate 180 per minute, respiratory rate 60 per minute, temperature 103, and saturation is 90%. So auscultation, bronchial breathing, right infrascapular area is hearing. So according to the WHO guidelines, any child presentation with any intercostal or subcostal recession with tachypnea, if saturation 94%, always think pneumonia. So now that I had a recent pneumonia etiology workup study shows that blend million study shows that's in India 61% having viral that's a etiology. But however, so according to WHO, you have to give the antibiotic and you have to properly send for the culture and start antibiotics. And radiological, you have to look for the radiological clue to etiology. And you have to look for lobar pneumonia, you can suspect a bacterial. In case child is having scattered lesions, and we can think of bacterial or viral. So you can, whatever the WHO guideline, you have to give antibiotic. After that, we can step down the antibiotic. So you can think of interstitial pneumonia, either you can go for viral or atypical like mycoplasma also you have to think of. So management wise, provide supplemental oxygen, airway management as needed, like we can use ABC, send investigations and start appropriate antibiotics. So you can start with empirical antibiotic for inpatient care after sending adequate blood culture and investigations. If a child is infant is having less than 3 months baby, we can start cefotaxime and aminoglycosides. You can avoid ceftriaxone less than 1 month because it's a ceftriaxone might bind with the albumin, may promote the increase the hyperbilirubinemia. So if child is having chlamydia or pertussis cough, we can consider macrolides. And babies having 3 months to 5 year baby, we can consider co-amoxiclav or we can go for ceftriaxone or cefotaxime. If baby is having more than 5 years, we can consider ampicillin or penicillin G, and we can go for co-amoxiclav or ceftriaxone or cefotaxime. And here we have to think of atypical mycoplasma. We can consider macrolides like azithromycin or clarithromycin. We can consider. In case of suspected staph infection, if suspected MSSA, we can think of cefuroxime or cephazolin. We can consider, and we can use co-amoxiclav also. Alternatively, we can use. And if a child is admitted, you need IV antibiotic, we can go for third generation cephalosporin. And MSSA coverage like cloxacillin, we can combination we can use. And in child is having MRSA suspected, we can go for vancomycin and teicoplanin and linezolid. So we can use linezolid. It's a parenchymal absorption good. We can consider linezolid, but we have to carefully use because we have to preserve the drugs for the tuberculosis. In case of suspected gram-negative pathogens, you have to consider ceftazidime or piperacillin, tazobactam, or ciprofloxacin with or without aminoglycosides. I think I've fairly covered okay, and if any questions, I think we can, as Dr. Abhay said, we can discuss it later. Thank you one and all for patient listening.